WPS is pleased today to present to you Enhancing Your Adaptive Behavior Evaluations by Dr. Patti Harrison. And as you know, WPS has been in business for over 75 years, and we are the leading independent publisher of educational and psychological assessments in the areas of autism, speech and language, school and clinical psychology, and occupational therapy. So thank you for joining us today. So I am pleased to introduce and have the opportunity to introduce our speaker today. Dr. Patti Harrison is a professor emeritus of the school psychology program at the University of Alabama, where she was a faculty member and program coordinator for over 30 years. Her research and scholarship relate to professional issues in school psychology and assessment methods for children with developmental and learning and behavior problems. She is a co-editor of several books, including the 6th edition and upcoming 7th edition of Best Practices in School Psychology. Dr. Harrison is the co-author of the Adaptive Behavior Assessment System, all 3 editions, with the beloved late colleague, Dr. Thomas Oakland. Dr. Harrison was the editor of the School Psychology Review and has been an editorial board member for major school psychology and related journals. Dr. Harrison served as the president of the National Association of School Psychologists and was the recipient of NAS's Lifetime Achievement Award and the Jack Barton Distinguished Service Award in APA's Division of School Psychology. She is a fellow of the American Psychological Association and the American Educational Research Association. So without further ado, I introduce to you Dr. Patti Harrison.
Thank you, Ashley. Thank you, Laura Woloff, and thank you all of Western Psychological Services for sponsoring this webinar today. I am thrilled to welcome you, to thank you for attending, to hear about the number of attendees from across the country and all over the world. It's pretty amazing. So thank you all for coming. Today we'll be talking about adaptive behavior, as the title indicated. Our learning objectives for the webinar this afternoon, are to focus on perspectives, current and historical perspectives of adaptive behavior assessment for individuals not only with intellectual disabilities and autism, but also a host of other types of developmental, learning, behavioral health issues. We'll talk about some of the adaptive behavior skills that are available with a focus on the ABAS-3, the instrument that I am co-author of. We'll talk about research that has implications for assessment and planning intervention. And finally, we'll talk about best practices in applying adaptive behavior assessment into a comprehensive model of database decision-making. As important for my ethical principles of my professional associations, I want to disclose that as author of the ABAS, I do receive royalties. Okay, the topics we're going to talk about today. We'll begin with talking about the major foundations of adaptive behavior assessment, moving into the rating scales that are used. We'll talk about the research, interventions, and concluding with best practices. So starting off with foundations of adaptive behavior assessment. Interestingly, adaptive behavior as a concept is very, very old. Before we had formal assessment instruments, when criteria were used to determine if a person had a disability, the criteria involved self-care, community engagement, independence, getting along with others, what we know as adaptive behavior. So pre-1900s, when we talked about a disability, including an intellectual disability or a mental health issue, the focus was on adaptive behavior, even though we did not have a formal measurement for that. Beginning in the early 1900s, that changed when we began to develop formal measures of IQ tests. And in the early 1900s, continuing for many years, probably even until now, a focus has been on IQ test scores to define disabilities. Certainly intellectual disabilities have been defined with IQ tests, but a number of other disabilities really relied on IQ test scores to define disabilities. In the mid 1900s, 1960s, 1970s, the overuse of IQ tests came under a lot of public scrutiny. A person at that time, Dr. Jane Mercer, who was a sociologist out of Stanford University, conducted a research study in Riverside, California. And in her research study in the schools of Riverside, she found that a lot of Black children were classified as having an intellectual disability called a mental retardation at that time, based solely on IQ test scores. However, once they left the schoolhouse and went home and out into the community, no one knew they had a disability because their adaptive behavior was just fine, the same as other children the same age. Dr. Mercer wrote a number of articles based on IQ, the lethal label, and focused on the importance of including adaptive behavior as a component of what would be classified as an intellectual disability. It was actually Dr. Mercer's work that led to my own interest in adaptive behavior. At the same time, there were a number of court cases looking at the use of IQ tests, or the overuse, sometimes the misuse of IQ tests for assessment and placement of children in special education. One of the most well-known of those cases was the Larry P. case in California, which still is used in assessment practices for children with intellectual disabilities. So the history of adaptive behavior is long, but there is a concern that there's a focus on IQ test scores, too much emphasis. And I think that agreement from professional standards to legislation is that, yes, there had been too much emphasis on IQ testing. The authority on intellectual disabilities is the American Association on Intellectual and Developmental Disabilities, AAIDD, which previously was called American Association on Mental Retardation. It, over the years, has defined what an intellectual disability is. Its first definition was in 1959, and adaptive behavior was recognized then. In each of the subsequent 12 definitions, there has been an increasing focus on adaptive behavior as a criterion for intellectual disability. And there, even though intelligence test scores are still used for that diagnosis, the focus on adaptive behavior has increased and increased. In the 1970s and continuing until now, special education legislation has also focused on adaptive behavior assessment. Special education assessment has agreed that there has been too much focus on IQ tests, and has indicated the importance of using multiple tools to assess specific areas of educational need, not just IQ tests, and that no single procedure should be as the only criterion for determining that a child has a disability. So, what is adaptive behavior? Adaptive behavior is pretty straightforward. We all have it. We all need it. We all use it. Adaptive behavior is everyday competence. Adaptive behavior is the practical everyday skills that we need to take care of ourselves, get along with others, to be independent. Some characteristics of adaptive behavior that we all have, we need those adaptive skills to function in our everyday life. Adaptive behavior is considered to be developmental. Increases and grows more complex as children grow older, as people grow older. It grows more complex to meet the demands and the expectations of the various environments and situations at home, and then at school, and then at work, in our social situations, in our communities. Adaptive behavior focuses on typical behavior, what we actually do in these natural environments. And that's important because it's not a maximum performance test. It's what we typically do in these various environments that we participate in. If someone has adaptive behavior deficits, then there are difficulties with these major functions, important life activities, including peer relationships, taking care of our own needs, learning new skills, general requirements for functioning in our various environments. It is important to appreciate that people may have adaptive behavior deficits that coexist with strengths. The AAIDD has emphasized that all along, that it's not deficits across the board for a person with an intellectual disability or any other type of disability. We tend to have strengths and weaknesses, and that's important for comprehensive assessment, to learn what the strengths and weaknesses of a client is and use that information to plan intervention and treatment programs. A factor that I emphasize for adaptive behavior assessment is that we do adaptive behavior assessment not only for diagnosis, but because it leads to interventions. And adaptive behavior interventions improve a person's life functioning. And we'll talk a little bit about some of the research that supports that, but adaptive behavior interventions work. We do it to help people function better in their environments. Adaptive behavior generally is defined by three domains of adaptive behavior. Factor analytic research supports this. Professional organizations support three major factors, domains of adaptive behavior. The AAIDD writes the most about it. They define the three domains as conceptual skills, social skills, and practical skills. And within those three domains are a wide variety of more specific types of skills. At one time, the AAIDD, in its 2002 definition, identified 10 adaptive skill areas within these areas. And those 10 adaptive skill areas are no longer used as part of the criteria for an intellectual disability, but help us understand what these three domains encompass. Let's talk about two major purposes of adaptive behavior assessment. One, of course, is diagnosis and classification, and the other is planning interventions. Looking at the diagnosis and classification purpose of adaptive behavior assessment, adaptive behavior assessment is important for a number of different types of issues and disabilities. It has been a required component of assessment for intellectual disabilities for many, many years, and professional standards, including the AAIDD, DSM, and IDEA, all require adaptive behavior assessment as a component of diagnosing an intellectual disability. Using the AAIDD definition of intellectual disability, its very latest one, 2021, this year, an intellectual disability is characterized by both limitations in intellectual functioning and in adaptive behavior, with adaptive behavior expressed in conceptual, social, and practical domains. And that definition of dual criteria of deficits in intellectual functioning and in adaptive behavior have been part of the definition of an intellectual disability for many, many years. AAIDD also points out that an intellectual disability originates during the developmental period or before the age of 22. The AAIDD and DSM also have criteria for adaptive behavior deficits. The AAIDD indicates that to meet that component of an intellectual disability, a deficit in adaptive behavior, one or more of the 3 domains will have scores 2 standard deviations below the mean. So the AAIDD actually gives a numerical cutoff for an adaptive behavior deficit for an intellectual disability. One of the 3 domains at least. At one time, the AAIDD, in fact, its last definition, recognized a global or total adaptive behavior score, and that has been dropped with this definition. The DSM doesn't have a specific cutoff score, but recognizes that when at least one of the 3 domains of adaptive functioning are sufficiently impaired, and that's the criterion for the deficit in adaptive behavior. Those of you who work in schools and work with the Individual with Disabilities Education Act of 2004, there is no numerical or specific wording in IDEA for what is a deficit in adaptive behavior. IDEA does recognize deficits in intelligence and adaptive behavior for a diagnosis or eligibility for intellectual disabilities, but doesn't have a score cutoff. And there's a lot of variation from state to state in their special education regulations about what is an adaptive behavior deficit. An excellent article by McNicholas and colleagues reviewed state special education regulations for intellectual disability, and there was a lot of variation, but 65% of the state regulations had no adaptive behavior score cutoff, and only about half had any reference to any type of score, whether it's a total score or domain scores or a type of informant, whether it's parent or teacher or both. So state regulations are not very consistent about what is a deficit in adaptive behavior. Adaptive behavior assessment is, although not technically part of the definition of autism, relates to the autism criteria in a number of ways, with the autism criteria covering factors that relate to adaptive behavior. So it's routinely used in adaptive behavior assessment of adaptive behavior is routinely used in autism assessment. Is emphasized in professional resources about assessment for autism. And one of the most frequent research in adaptive behavior assessment in this day and age is research with children with autism. Adaptive behavior assessment is also a key component of developmental delay for those states that have developmental delay, using the IDEA definition of a delay in one or more of the developmental areas of physical, cognitive, communication, social, emotional, or adaptive. So it's one of those areas, but adaptive behavior assessment often provides information about the other developmental areas too. And adaptive behavior assessment has a lot of implications for a lot of other client difficulties, disabilities, disorders, challenges. It should be assessed routinely if there is a problem that may interfere with a person's daily functioning and their ability to take care of themselves and get along with others. It adds to the comprehensive evaluation to determine strengths and weaknesses of those areas, but in my opinion, most importantly, has a lot of implications for interventions. So adaptive behavior assessment has implications for attention deficits, emotional disturbance, learning disabilities, behavioral disorders, traumatic brain injury, for older individuals, dementia, stroke. And there's research to support that individuals in these areas often have challenges with adaptive behavior. The second major purpose of adaptive behavior assessment, which I emphasize, is for designing interventions. So for designing interventions, training, treatment programs, there is a need for a focus on skills needed to function at home, school, community, and when is there not a need to have those skills? But it allows, focuses on skills that allow people to be independent. It allows us to identify strengths and needs. And with most individuals experiencing a disability or some sort of difficulty or challenge, we're often focusing on what skills are needed in the current environment, but also looking at what skills do we need to develop for a transition to the next environment. So for example, if someone's in an early intervention program, a young child's in an early intervention program, we're always looking to what's needed in a school program. School program, we're interested in transition from elementary to secondary, and of course from school to work. So the transition to the next environment is an important component of the interventions and training and treatment that we emphasize for teaching adaptive skills. Adaptive behavior rating skills. The AAIDD stresses that an adaptive behavior assessment to determine deficits needs a standardized norm referenced individual measure normed on people without disabilities, including those with disabilities. And there are a number of adaptive behavior scales. The two major ones are the ABIS and the Vineland. Although there are a number of other adaptive behavior skills that are used. Adaptive behavior skills are generally rating skills. So we are asking respondents to respond to items and rate how frequently a person is performing the skill described in that item. The ABIS, we're now in the third edition, is an instrument that I developed with the late Dr. Tom Oakland. As Ashley mentioned, Tom Oakland, a very widely respected psychologist who many of you may know and who we miss greatly. So I would like to express my appreciation for what he has done over what he did over many, many years. The ABIS has 5 rating forms, 2 for early childhood, a parent and a teacher form, 2 for school age, a parent and a teacher form, and then an adult form, 1 form that can be completed by a person's familiar with the adult client, or if it's appropriate, by the adult client themselves. The ABIS follows the domains of the AAIDD. So there are 3 major domains measured by the ABIS: conceptual, social, and practical. Those combine for a total score called the General Adaptive Composite. The ABIS has specific skill areas within each of those domains that actually follow the skill areas developed by the AAIDD and its 2002 definition. So with the conceptual domain, communication, functional academics, self-direction; the social domain, leisure, social; practical domain, community use, home living, health and safety, and self-care. There's an optional work domain for older adolescents and adults who work, have employment. And then an additional motor skills domain for young children. The respondents for the ABUS, parent, teacher, caregiver, rate each of the ABUS items with 4 possible ratings. The first decision that the respondent makes is whether or not the person they're rating is able to do that behavior or not able. And that's something that is unique with adaptive behavior assessment, and something that Dr. Oakland emphasized a great deal, that it's important to not only know how often, how frequently a person performs that behavior, but if they're able to. And if they're able to, but they're not doing it, that has some implications for intervention compared to if they're not able to perform that activity. So the ABUS ratings are circle 0 if a person is not able to do it, but if they are able to do it, then the respondent rates the frequency. 1 if they are able to, but they never or almost never do it. So a child who is able to tie their shoes, but almost never do it. 2 is circled if the person sometimes does it, and a 3 if they almost always do it. The ABUS also allows the respondent to check if they weren't sure, if they needed to estimate or guess. The scores for the ABUS 3 include normative scores of standard scores for the composites and general adaptive composite, with confidence intervals as well as percentile ranks. And then for the adaptive skill areas, those are scale scores, mean of 10, standard deviation of 3. The ABUS has a number of additional resources. One that is an important and useful resource is an intervention planner that's available in a paper manual version as well as an online version. There are paper and online administration and scoring, interpretive reports, parent and teacher reports, and progress monitoring reports. Another very widely used adaptive behavior scale is, of course, the Vineland. The Vineland was the first adaptive behavior scale. Started out in the 1930s, 1940s as the Vineland Social Maturity Scale. And the author of the Vineland Social Maturity Scale, Edgar Dahl, was a highly respected psychologist well before his time in emphasizing the importance of adaptive behavior, which he called social maturity, for people with intellectual disabilities. It's now called the Vineland Adaptive Behavior Scales in its 3rd edition. There are 3 forms: interview form, parent caregiver, teacher form, and each of those forms has a comprehensive version or a domain level version. The Vineland has 3 domains comparable to what we see in the AAIDD definition: communication, daily living skills, socialization. And within each of those domains, the subdomains are listed there on the slide. The Vineland also has an overall composite score, the adaptive behavior composite. The Vineland has optional domains, motor skills, and maladaptive behavior. The Vineland ratings, they don't have a can or cannot rating as the ABUS does. Their rating is based on frequency of performance, usually, sometimes, never. But like the ABUS, the Vineland has a check if estimated component for these ratings. The Vineland normative scores are typical scores. The composites have a mean of 100, standard deviation of 15. The subdomains use a V-score scale, mean of 15, standard deviation of 3. And of the Vineland also has a number of additional resources, paper and online score administration and scoring, online reports, progress monitoring reports, and the Vineland also provides item level comparisons for comparing between raters and progress monitoring. And there are a number of other adaptive behavior scales that we won't go into. There is the SIB, the Adaptive Behavior Evaluation Scale, the Adaptive Behavior Diagnostic Scale, the Diagnostic Adaptive Behavior Scale, which is actually a scale published by the AAIDD, and other adaptive behavior scales. Something that's important to note is that broad behavior rating scales generally are not considered adaptive behavior scales. Adaptive behavior is defined by professional standards as skills needed to take care of oneself, get along with others, function independently, and the conceptual, social, and practical areas. So the broader behavior rating scales generally are not adaptive behavior scales. Let's talk some about what these rating scales do, some implications for how we use them in assessment. A first factor to consider when you're assessing adaptive behavior is the factor that I discussed with the ABIS, that the ABIS does within its item scoring, that there is a distinction between typical performance versus skills. So if a person has a deficit, understanding if it's a skill deficit or a performance deficit is important. And if the person does have the skill, understanding the frequency of their performance, that they do it in their real world when needed, without reminders, without assistance, is an important component. Another factor in adaptive behavior assessment is that the adaptive behavior instruments can be completed and are normed with multiple types of respondents. And it's very much recommended that multiple respondents will give us the best picture of adaptive behavior. So with children, a parent and a teacher, what a child is doing with adaptive behavior at home is as important as what is the child doing in school with adaptive behavior. So for the best adaptive behavior assessment, comprehensive adaptive behavior assessment, we need to use multiple respondents to understand the adaptive behavior that's being displayed across multiple environments, how a child is responding to the demands and expectations in those environments. And triangulating that information along with other assessment information to get the most comprehensive picture of a client and what the client is doing. Now, rating scales have advantages and limitations, and some of the questions that some of you submitted ahead of time dealt with some of the advantages and limitations of rating scales. An adaptive behavior assessment is a behavior rating assessment, and all behavior rating scales have advantages and limitations. Frankly, all assessments of human beings have advantages and limitations that we do need to always keep in mind. Now, with behavior rating scales, including adaptive behavior scales, there are a number of advantages. It allows for a comprehensive assessment of many skills and involves important people in the assessment process. It provides information from multiple perspectives, multiple environments. There's a focus on what people are actually doing in those real environments. And it's a behavior rating scale is considered to be one of the most valid, practical, efficient techniques for assessing behavior, including adaptive behavior. But given that there are limitations, it doesn't mean that behavior rating scales are not valid, that they're bad. They're very good, but we need to know what the limitations are and take into account those limitations during interpretation. With behavior rating scales, a person's rating of an item is not an exact frequency based on as if you were doing a direct observation, but it's a summary of the relative frequency. It reflects the respondent's expectations and standards. and those may differ from respondent to respondent, from setting to setting. Those of you who work in schools, you walk into 2 different kindergarten classes and you see very different expectations for the behavior of kindergarten children based on the teacher's expectations. So with adaptive behavior assessment, we get the best assessment with multiple respondents. Those respondents' ratings do also reflect their honesty and objectivity in communicating the information in a rating scale, and sometimes it can be influenced by other characteristics of the client being assessed, their cognitive ability, their background, or it can be related to factors related to the respondent too. So what we do in good adaptive behavior assessment is we take into account that there are going to be limitations with behavior rating scales. We do all we can to promote the best possible adaptive behavior assessment by establishing good rapport with the respondents, preparing the respondents, focusing on the purpose of assessment, how honesty and objectivity is important, providing the respondents instructions about the criteria for the ratings, explaining what is the difference between a skill and a performance, and being available for questions. Following the assessment, analyzing the rating forms, the item scores, paying special attention to items that were estimated. If there are differences between respondents, following up with respondents with interviews, observations. So like with any assessment, a comprehensive assessment is just not, is a lot more than giving the scale to someone to complete the items and scoring it in that static. It takes careful consideration of what we're getting. The pandemic and our virtual world has had a lot of implications for assessment, including adaptive behavior assessment. And Western Psych has developed a wonderful set of materials talking about virtual assessment. And because the ABAS can be administered online, it's being administered a lot during this pandemic. But there are some excellent implications for adaptive behavior assessment and how we need to take that into account if it's a virtual classroom and what the teacher is seeing, what parents are seeing more so at home, what children are experiencing more so at home. And all of those have important implications for adaptive behavior assessment. So do check out this great resource. Now let's talk about some research. And we won't spend an awful lot of time on research. The slideshow, when you get it, will have a number of references. But some of the major areas of research that I've decided to focus on are those that have the most implication for assessment of clients with disabilities as well as other clients. One area of research that is very important, given that intellectual disability requires both deficits in intelligence and adaptive behavior. What are we talking about? Are we talking about a strong relationship between intelligence and adaptive behavior? Research has consistently found that adaptive behavior and intelligence measure distinct but related constructs. The research by Alexander and Reynolds in 2020 was a meta-analysis of a lot of research studies, and they found that generally the correlations between adaptive behavior and intelligence are in the 0.50, 0.51 range, so very moderate. So we're talking about related constructs, but very distinct. Some of these relationships can be a bit more complex. There tends to be a higher correlation for younger children or a higher correlation for individuals with lower IQ, with children with autism. Children with higher functioning autism tend to have a lower correlation between intelligence and adaptive behavior. Their intelligence is a lot higher than their adaptive behavior. in comparison to children who are low functioning with autism. And understanding that there may be inconsistency between a person's adaptive behavior and intelligence test scores, we need to understand what we're talking about. Intelligence test sample maximum performance. We're generally talking about traits, and we presume stability. Adaptive behavior scales, we're talking about everyday behavior and natural environments, seldom talking about a theoretical trait system. And importantly, we presume that adaptive behavior can change, as research shows. Another area of research that is important, and from the questions you submitted ahead of time, I know that many of you encountered this, the correlations between parent and teacher scores. We emphasize the need for multiple informants, but what if they don't agree? And the correlations do tend to be moderate to moderately high. It's not, there is some presumption that parents inflate and teachers are more realistic, or teachers deflate scores. And that's not always the case. For example, studies with children with autism show that sometimes teacher scores are higher than parent scores, especially if parents are dealing with the expectation, much lowered expectation once learning their child has autism, where teachers have more experience with other children with autism, so their expectations may be higher than parents in those cases. But those research findings do show that the correlations tend to be moderately high. And it's important to investigate why, given this research finding that parents and teachers may not agree. Keep in mind that people do behave differently in different settings. So it could be that a child is behaving different in an adaptive behavior sense in home and school. There are different expectations. There may be a lack of information. There is honesty and reporting what a child is doing. But all of this indicates that it's very important to use multiple informants and interpret the similarities and differences, looking at the why. And the why is important not only for making eligibility decisions, but very important for interventions. There are many research studies with different clinical groups. I'll go through these quickly, but the purpose of showing these clinical groups is to demonstrate that adaptive behavior assessment has implications for a lot of people, and not just intellectual disabilities. The research findings with intellectual disabilities show clearly that with intellectual disabilities, they consistently have scores lower than 2 standard deviations below the mean, significantly lower than control groups. There are studies that look at different components of intellectual disabilities. For example, the study by Papazoglu and colleagues looked at the impact of executive functioning and externalizing and internalizing disorders, and showed that adaptive behavior was an impact for those groups as well. I said earlier that the group with the most research right now is children with autism, and research demonstrates that children with autism have lower adaptive behavior, particularly in communication and social skills, as one might expect for children with autism. A number of studies look at children with higher functioning, children with autism with higher functioning, and they too have significant deficits in adaptive behavior, but higher IQ. Autism criteria, autism behaviors related more to adaptive behavior than intelligence related to adaptive behavior for children with higher functioning autism. And again, relative weaknesses in social skills, but strengths in academic related skills. This study by Lopata and colleagues looked at both the Vineland 2 and the ABUS 2. This was before the ABUS 3 and Vineland 3 came out. A developmental delay, significantly lower scores, but not as low as for samples with intellectual disabilities. And other research findings include lower scores for ADHD. With the ABUS, the lower scores were in self-direction, that skill area. For the Vineland, lower scores in socialization, communication. Lower scores for children with emotional or behavioral disorders. For our learning disabilities, with the lowest scores in communication, functional academics, and self-direction. And a lot of research with different physical health and sensory disorders, showing lower adaptive behavior scores for children with visual or hearing impairments, for example, traumatic brain injury, neurological impairment after stroke, spina bifida. And I'm just giving some samples of a lot of research that shows that a number of clinical groups, a number of people who are having problems and disorders have impacts with adaptive behavior. Assessment with adaptive behavior can not only have implications for comprehensive assessment and diagnosis, but again, I keep saying, excuse me, for interventions. So, about interventions. Adaptive behavior interventions are important for many reasons, but for improvement of a person's life functioning. So depending on the age of the client, what environments they are functioning in, whether it's home, school, community agency, work, a focus is on what is needed to function now, as well as for movement into the next environment. And something that the AAIDD emphasizes, and I very much agree with, is that we need to take into account personal preferences too, and satisfaction. So higher priority skills are those that are critical in personal self-care, domestic health and safety, those that are highly preferred. I'm so sorry. Those that promote independence. And lower priority skills are those only learned with difficulty. Sorry, got a tickle in my throat there. The ABUS, as I pointed out before, has an intervention planner. And the intervention planner is a unique component not found with other adaptive behavior skills that has a mechanism for first administering the ABUS and identifying skills that are specific needs for development. And those include items rated 0, 1, sometimes 2, forming objectives related to the highest priority needs from those items that an individual cannot do or is not doing. Selecting intervention strategies and using the ABUS to monitor progress. So the intervention planner has intervention activities for each and every ABUS item on each and every form the ABIS. These are some sample intervention items for the ABIS intervention planner. Does research support the effectiveness of adaptive behavior interventions? Yes, very much so. There is a lot of research just focusing on specific adaptive skills, and it may be domestic skills or self-care skills. There's also quite a bit of research that looks at specific types of interventions and their impact on adaptive behavior scales and increasing adaptive behavior scale scores. Some of the selected research that I've identified here on the slide and include more hours of early intervention services for children with disabilities leads to gains on adaptive behavior skills. Cognitive interventions for children with neurodevelopmental disorders, emotional intelligence training for adolescents with intellectual disability, early behavioral interventions for children with autism. These studies show an increase gains in adaptive behavior scores on adaptive behavior scales. So just a few interventions suggested here that lead to improvement in adaptive behavior. Now let me conclude with sort of giving you my wish list of what I'd like to see happen with adaptive behavior assessment. A wish list I've developed over many years of working with people and working with adaptive behavior assessment. Best practices. Emphasize comprehensive adaptive behavior evaluation as a major factor in your assessment practices, as a major factor in your intervention practices. Focus on comprehensive assessment using multiple respondents across multiple environments, multiple methods. Rating scales are an important method that is emphasized for the standardized norm reference scores, but also there are a number of methods with interviews, observations of talking with children. A third recommendation is never use a single procedure as the sole or even primary criterion for a diagnosis, classification, or eligibility. This holds true with IQ test scores, but any other type of assessment. No single score should be a decision maker. People should make decisions based on comprehensive information. Test scores should not make decisions. When assessing individuals in a comprehensive evaluation, and interpret the many reasons why there is or is not a convergence of information. Intelligence and adaptive behavior scores may differ. Academic and adaptive behavior scores may differ, and interpret why there is and is not a convergence of information. Some of the research that I presented suggests some of the reasons that you would look at in interpretation. Explore many factors that can impact a person's scores, taking into account the advantages and limitations of behavior rating scales. I have administered adaptive behavior skills to many parents and teachers, and there are many factors that can impact not only the respondents' expectations, children behaving differently in home, in school, and why. I've talked with many parents of children with significant disabilities who admit that their child can do something adaptively, like tie shoes, but it's just easier for the parent to do it, for example. Overall, stress adaptive behavior assessment as an important intervention tool. Adaptive skill improvement is an important intervention goal for many, many people. And then finally, incorporate adaptive behavior assessment into data collection and interventions for all individuals. experiencing problems, because if a person is experiencing almost any problem, it's going to have an impact on their adaptive behavior. Now, I'm not saying administer an adaptive behavior rating scale for all individuals, because it needs to be guided by your assessment needs to be guided by a person's needs. But at the same time, it's very, very important to understand, and the research supports that a lot of people experiencing problems do have adaptive behavior problems, and their functional daily living skills and independence should be a focus of interventions. So thank you for attending. I'm going to turn it back over to Ashley right now.
Thank you, Dr. Harrison, for a great presentation. I hope everybody got a lot of questions answered. I know I was busy in the Q&A. We were busy in the chat as well. So thank you. So a couple of resources we just want to point out before we conclude our webinar today, and we will answer a couple of questions as well because we do have some time. First, we wanted to point out our telepractice page as well. I think you will find a lot of great resources on there, including many questions that were asked of us in the Q&A as well about using remote assessment and how to go about that and getting valid information. So you'll see a assessment validity concerns during COVID, as well as a FAQ section as well. So in addition to our telepractice page, we'd also like to point out our resources page as well. So as you can see on the next slide, you'll see that we have our online evaluation system, which is at platform.wpspublish.com. We will also have, we would like to point out our YouTube channel as well. There is also a unboxing video of the ABIS 3 on there as well. In addition to that, we also have our telepractice page that we mentioned, video resources as well. So for attending the webinar today, we do have a discount code that is shown for you on the next slide for 15% off the ABIS 3 or the ABAS, however you say it, all that is the number one question we probably do get on the product. What is the correct pronunciation of the product? And like everything in our field, the answer is it depends. So there is no right or wrong answer. So Dr. Harrison, if you don't mind proceeding to the next slide. So yes, there's the resources that I mentioned as well. And so like I said, you will get a copy of this PowerPoint. We do encourage you to check out our online evaluation system and our YouTube channel, as well as our telepractice page. And so on the next slide, you will see the discount code for the ABIS 3 as well. That's 15% off if you will use the code mental health 21W, that will entitle you to the discount. Then on the next slide, here at WPS, we have a variety of assessment consultants available to help you. Here's a picture of all of us and my wonderful colleagues as well. And then on the next slide, you will see the map of the United States and the territories as well. So I know it's hard to read right now on the screen, so don't strain yourself right now. Like I said, you will get a copy of the PowerPoint slides, and you can use the map to locate your WPS assessment consultant for your particular state. Their contact information is listed there. All righty, and then finally, you'll see if we didn't get to your question, and I apologize, they were coming in fast and furious. I was trying my best. Feel free to reach out to us on our Contact Us page. You'll see our customer service information there, as well as contact us by email. So we have just a couple of minutes to go over some questions. So one of the ones we got was the revision to the ABIS 3 is still several years out. So that's, you're good for the next couple of years for sure. Dr. Harrison, I think one of the questions that came up several times in the chat was any tips for addressing the confusion respondents have on the ABAS 3 and determining whether a behavior should be rated a 0 or a 1.
Okay, thank you, Ashley, and thank you for that good question, whoever raised that question. It's a question that we get a lot. As I was talking about the ABAS 3, I pointed out that component of the scoring, which is a relatively unique way of scoring an adaptive behavior scale. That a first decision about whether a person is able to do something. If they're not, you score at 0. But if they are able to do it, do they do it? And how often they do it. And I pointed out that that was something that very important. It was a component of the initial development of the first ABAS, something that Dr. Oakland and I discussed a great deal, and we continue to discuss it with every revision, because we feel it's important to be able to determine if a person, a child, another client is able to do something, and if not, do they do it? If they are able to do something and they do not do it, it's important to try to understand why, and that has a lot of implications for intervention. Because this topic was so important to Dr. Oakland, especially, in the ABAS manual, you will see that there's quite a bit of discussion about it, and some scripts and guidelines for how to explain it to parents or teachers who don't understand it. The notion of performance deficits and skill deficits, and explaining that to parents and teachers can assist a lot with that, plus giving an example. So I often bring up the example, if a child they are able to tie their shoes, but they don't do it, understanding why has a lot of implications for what a person's adaptive behavior is. So we have that built-in system for can do, doesn't do, and we continue to find that important.
Excellent. Thank you, Dr. Harrison. I know that that is a question that gets asked a lot. So another question that came up is, can the ABAS 3 be used in an interview format or read to parents?
And the answer is yes, but it's important to read the manual because it has some guidelines for doing so. It was normed with a rating scale, independently reading and responding to the rating scale. So that is the way it was normed. It's important in our profession as when we administer assessments and use the norms, that we administer them the way they were normed. So
important, and I think
yeah. So with the manual does point out, looking at the manual now, that the ABAS can be administered in an interview format. If it's administered solely in an interview format, the results should be used with caution, primarily qualitative. What some people do for an interview format is that they have the standardized administration first and then follow that up with an interview. Yes, items can be read to the respondent, the scores can be used, but there should be a note in our report, our decision making, that the items were read to the respondent.
Absolutely. Thank you, Dr. Harrison. And I think that just goes to the importance too of reading the manual. And I know that that's just so hard, for day-to-day practitioners sometimes, and especially if you're a seasoned practitioner and you've been using the instrument for a while. But you'll find valuable information, and on the ABAS 3 manual, there is actually a frequently asked questions section in the manual as well. I know as a practitioner, I always had that page flagged as well. So I encourage you to do that as well.
Very good.
If we were unable to get to your question today, please email consult@wpspublish.com. And we want to thank you for joining us today. And hopefully we have taught you how to enhance your adaptive behavior evaluations. Thank you all.